Good morning, hello, and welcome to the 2024 Department of Health listening sessions regarding behavioral health licensing. Thank you very much for participating. Please be advised, we are recording this meeting. My name is Joe Miller, and I am one of two executive directors for the behavioral health professions with the Office of Health Professions at the Department of Health, and I will be facilitating today's listening session. Now, I'd like to have the other department staff on this webinar introduce themselves. Then I will give some instructions for using Zoom. After that, we'll hear a brief presentation on the department's efforts to improve credentialing processes. Then I will give a brief presentation on the recommendations we made in December to reduce barriers. Then we will begin the listening session and gather your comments. When we have about 5 to 10 minutes left in the meeting, we will wrap up comments, and I'll provide a quick overview of our next steps. With that, I would like to ask our panelists to introduce themselves as I call on you. Harold.
Yes, hello. I'm Harold Wright Jr. I'm the Deputy Director of the Office of Health Professions, and I'm excited to be here with all of you today.
Eve.
Hello. Thanks for being here today. My name is Eve Austin, and I am one of the other behavioral health executive directors as well. Thank you, Joe.
Brandon.
Hello, my name is Brandon Williams. I'm the project manager associated with 1724 and 2247 with the Department of Health Office of Health Professions. Thank you.
Lana. Or Zach, please.
Good morning, everybody. My name is Zach Patnode. I am a quality administrator with the Office of Health Professions leadership team. Thanks for having me.
Thank you. We do want to note that there are several more DOH staff on the webinar with us this morning, including some of our other program managers for all impacted professions and representatives from customer service. But in the interest of time, we will not have everyone introduce themselves. If you'd like to contact any of our program managers, their contact information is on the second to last slide of this slide deck, which was shared with registrants on Monday. Now, before we begin, we wanted to provide some basic instructions for how to interact with Zoom. You should see a control panel along the bottom of your screen. If your mouse has gone inactive, it may have minimized itself, so try shaking your mouse if you do not see the control panel. On the far left of your control panel is a button to mute and unmute yourself. The button is currently inactive, but we will enable your microphone if you raise your hand to speak. Towards the center of the panel, you will see buttons to open the list of participants, the question and answer box as well, and the chat box. To the right on your control panel are options for closed captions, interpretation, and reactions. When we call for folks to raise their hand, you will find the hand raise button in the reactions menu. We are also providing ASL and Spanish interpretation for this meeting. ASL interpreters should be pinned to your screen. If you cannot see the ASL interpreters, please put that in the chat and one of our team will enable that. If you'd like to switch your audio to the Spanish interpretation, click on the globe shape icon in the bottom right of your screen, and it will say interpretation underneath it, and select Spanish to hear the translated audio. I would also like to remind everyone, if you are a fast talker like myself, please try to speak slowly to make things easier on our interpreters. Also, video is turned off for attendees by default. If you need to access to share your video, please put that in the chat and we will enable that feature for you. Zach, at this time, feel free to share your screen, please. The Office of Health Profession recently started a merger absorbing the credentialing function in efforts to support credentialing process improvement. It's been a pleasure to be a part of our credentialing process improvement leadership team. I now support our mental health counselor credential types, the MHC, MHCA, marriage and family therapists, our MFTs and MFTAs, the social worker group, which is the SWA, SWI, SWAA, and the SWIA, the psychologist license, both probationary, temporary, and full licensure, and the sex offender treatment providers, SOTPs and SOTA. My team of program managers who guide the professions has merged with the credentialing staff on March 1st. And I'm proud to share that we have improved communication, increased collaboration, and we are beginning to see data-driven results resulting in declines in our credentialing timeframes. But my story is just one of many of our my office mates. I will share, we will continue to support these credential types in the next weeks and months to decrease our processing timeframes. I will now turn the floor over to our Deputy Director, Harold Wright, and his team to provide an overview of the work that we've been performing. Harold and Zach, the floor is yours.
Excuse me. Thank you, Joe. I appreciate this. Now, I recognize that this listening session focuses on rules and statute and how to remove barriers. But what I wanted to share, what we wanted to share as a department, is that we heard you regarding credentialing being a barrier last listening session. So we took that information and we engaged in a pilot to implement process improvement tools in the attempt to construct a consistent process that led us to, or hope to lead us to, consistent decreasing the number of applications that come through our office. Zach and I today will present at a high level an overview of this process and share what we've learned and how that learning has contributed to the reorganization efforts that we're currently undergoing. But I want to say our director, Shauna Fox, had another engagement. She was here the last couple of days, but wanted to make sure that we shout out her and her leadership around this work as well. Myself, Harold Wright Jr., the Deputy Director, and Zach Patnode, our other administrator of the Office of Health Professions, CQI Administrator. He'll introduce himself as we go forward. So again, like I indicated, we use the data to undergo our current reorganization, but it began here. It began by using psychology as a pilot to figure out what we could learn, what we could do in order to build out a process that was more effective. And so some of the psychology challenges that we had was, it was a complex board in its sense, not just the board, but I mean the work, in terms of reviewing the applications. And sometimes the timelines can be very long. There had multiple offices and many people that needed to be on a very early stage engaged in the process that just wasn't there at all times. It also has an independent board authority that makes the decisions, but then DOH produces the credentials on its behalf. So again, there needed to be some alignment around that. So there were other challenges, but these are some of the ones that I believe had, and we believe as a team had some of the priorities. So we took that along with others and we embedded a process, a pilot that we could kind of sample and see what are some of the things that we can streamline, what are some things that we can make more efficient. And so we did that by launching Project Pathway. And in that pilot, we had a single leader. I helped, I led the process with Zach and a team. And we had also designated resources. And in that, we focused on culture, communication, and data. And Zach now is going to get on and talk to you a little bit more about that approach.
Thank you, Harold, and thank you again, everybody, for having me. I'm definitely excited to talk about this work. So given the short period of time we have to present today, I won't go into as much detail as sometimes we do when we present these pieces. But again, in this pilot, we knew generally what our challenges were at a high level. And we started to lean in and we created data reports that would allow us to better understand the detail of those challenges. And from there, triage and diagnose areas that needed improvement. Some of those were around non-routine applications that needed additional review by the board. Some of those were web page and frequently asked question needs, revisions to the forms that our applicants were using, their application itself, and supplemental forms, and a number of other places across the process that needed some work. In doing so, we were able to make improvements and then track those with our data over time, all the while learning and thinking ahead of how we might be able to use those same lessons for all of our professions, not just psychology and not just behavioral health, but all of the healthcare professions that we license as an office. And I'm proud to say that the work that we put in paid off in results, again, that we could measure. First, I'll show specifically for those non-routine applications that were being reviewed by members of the psychology board. When we started, there were a total of 54 of those pending. And over the first 6 months or so of that project, that number reduced all the way down to about 12 and has maintained near that area in the meantime. And so that's a really great piece to highlight, but maybe even more importantly, on the right chart titled non-routine process status count, the red line starting very high up there at 31 represents applications that were simply waiting for board review. They were in line. They were not being touched or reviewed or processed yet. They were waiting for a turn to land with a board member or team of 2 board members. And by a number of changes, including adding pro tem members and adjusting which applications were in fact non-routine, we were able to reduce that number from 31 down to 0 over a similar timeline. And that number has remained that way since, where applications that are named as non-routine and categorized that way can often be sent to the board and begin review on that very same day. For all applications, we also had data to indicate that we had twofold success in the project, both along that top line labeled before 12/9/2022. Those are applications that were already 3 months or older by the time the project started. And we issued 121 of them between the beginning of the project and the end of February of this year, and 123 new applications that were received since the project began. So we were very balanced in terms of cleaning up that which was already aged and improving our processes for those that we were receiving while doing the work. And so you can see a very drastic difference between how long it took to do issuance for some of those very aged applications, which was great to be able to get people across the finish line who had been trying to navigate the process, but also cleaning up our process so that those in the meantime coming in were moving through much more quickly, averaging around 90 days. And again, with an average, you have some applications that go through multiple rounds of this non-routine review and negotiation with the board that are always going to drive your average up a little bit. But by being, we had set out to get that number at or under 90 days and fulfilled that goal. And so this is an example of one of the scorecards that was developed out of the lessons that we learned. This one happens to exist for one of the behavioral health teams led by our leader, Eve Austin, who's with us here today. And so we now have data for all of our professions that tells us total applications and intake numbers and finals. So we know our starting point. We understand the nature of the work that we are going after to clean up. And we can track this on a weekly basis to make sure that the interventions that we are choosing are having the intended impact. And we can continue to reconfigure and add resources and tools as those things are needed. And I'm going to hand back to Harold here to talk a little bit about the cultural and interpersonal pieces of these things. I've been highlighting in these presentations that I'm very proud of the tools and the data that we have in place, but those things fall short if trying to use them on their own. The how we use them and how we think about the work and how we work as a team are equally important and really a dependency for being able to use the tools effectively. So Harold, back to you.
Thank you, Zach. And I think Zach hit it right on the head, right? Is that all the tools are great, but we have to have people prepared and resourced in a way that allows it to be applied. And so one of the things we did to move it from just transactional to more transformational is move the cultural and interpersonal framework pieces together. We need to ask ourselves how we saw our work. how does our systems, our culture, and our language take ownership of this entire process? At the time, that process didn't exist, so we needed to build it up. We needed to see what it looked like. We needed to ask the questions. We needed to be responsible from the receipt of the application to the issuance of license. How do we change and continuously improve? What's the next question? How do we make the data-driven decisions and make the invisible visible? So we know where our starting and ending points are, so we can refine and continue to get better as we learn more. And then we also know that language matters. We need to be speaking the same language. We need to look at moving from a deficient perspective to incomplete when we talked about applications that came in, and start talking about having a backlog to pending. So we're more asset-based in our communication, because we needed to have partnerships. And our partnerships need to be understood that we're looking for the same goal, to ensure that the folks that are licensed can meet the needs of the people in the state of Washington in a safe manner. But we do that by having these conversations, cultivating these type listening sessions, so we can go back and figure out what do we need to do on our end to be good partners. And then we need to evaluate the issues and implement improvements that were already raised. Those things that were raised before, are they still viable? Next, please. But who are we today? How does all the pilot, as Zach said, that was focused, in on psychology, but more importantly, how do we use those lessons across all of our professions? Here are some of the early accomplishments. We've transitioned our first group, the behavioral health team, on March 1. We had our second team come over April 1. And then our last team just transitioned May 1. And I won't read them all to you. Just take a moment to look at some of the early accomplishments. The thing that I do like to point out, though, is the morale and productivity continues to be high. And what I like about that is, again, none of this can happen without the people. Asking, talking, serving them. And they're excited about wanting to do a good job. No one goes to their job and not want to do a good job. How do we resource them, organize them in a way that they could be the most effective? Our next steps. Our next steps, again, is our data-driven tools. We want to make sure we move initial scorecards from all credentialings to a weekly cadence. Instead of going monthly, we want to look at the data more frequently, make adjustments, set meaningful targets, and then pursue more detailed data as resources align. Again, policy alignment. Technology evaluation. Want to make sure we're getting right size in terms of staffing and resource allocation. And again, constituent engagement. We have to be able to communicate and continue to establish our credibility. Now I'm going to turn it back over to Zach, and he's going to explain a little bit more about Helms Light. I want to thank you again for the opportunity to come and talk with you folks around this work, and we look forward to sharing some more in the future.
Thank you, Harold. And so we did want to additionally highlight a separate project and something that's been in the works longer than this pilot or even mine and Harold's tenure with DOH, which is the implementation of Helms. Helms stands for Healthcare Enforcement and Licensing Management System, which is the name of our new database that is in process of being implemented. Helms is going to be rolled out in 3 phases, the first of which just launched on April 24th. Specifically, Helms Light, this first phase, replaces the existing customer application portal. So applications still go through SAW, but are now using a new interface that has a number of different enhancements beyond what was previously being used, including being able to submit from a mobile phone or device, updating a profile, including locating and editing applications, which we expect to give enhancements and efficiencies, to delete draft applications, attach required documentation, and to print payment confirmation and receipt. So we're excited about these early gains. The credentialing module of Helms is expected to phase in December of this year, and then the discipline and investigation piece sometime in 2025. So as this moves forward, we'll be hoping to capture the opportunities that are already in helms and look for new ones as well to continue this progress of trying to continuously improve. And so we have contact here for Harold, for Shauna, our office director, for myself, for the Helms team specifically, if there's questions about that tool. And just to repeat again that we're very interested in engaging with our constituents about this internal operational credential work, and we want to hear from you with questions or thoughts or feedback. It's so key. The whole reason that we are doing this is to better serve Washingtonians and those our applicants who are moving towards licensure. But again, the focus of today's listening session will primarily be on rules and statutes and barriers in that area. So please do reach out if you have questions, feedback, ideas around the more operational pieces. And thank you again for having us. Very grateful for the opportunity to share what we're working on in this project. And back to you, Joe.
All right, thank you both Zach and Harold for that presentation. And so now for a couple brief slides on our 2023 recommendations for statute and rule change to reduce barriers to becoming licensed or maintaining licensure. I want to thank everyone who participated in our 2023 listening and feedback sessions. Your thoughtful comments and feedback helped us identify major hurdles and develop the recommendations I'm about to share that ultimately became law during the 2024 session. This slide shows the recommendations the department made for statute changes to reduce barriers. All these recommendations were adopted as part of INGRO's second substitute House Bill 2247, except for the recommendation to adopt the Social Work Compact, which was included in Substitute House Bill 1939. Effective June 6, 2024, the limitations on the number of renewals for master's levels counselor associates and substance use disorder professional trainees will be eliminated. Limitations on training locations for substance use disorder trainees will be removed. Time limits for earning supervised experience for substance use disorder trainees will be removed. And an allowance for master's level counselor associates to continue providing services to established patients while their application is pending becomes effective. Effective October 1st, 2025, a new credential for psychology associates will be available. The Examining Board of Psychology is granted authority to create standards for licensure without exam that reflect the applicant's professional experience. Continuing education requirements for master's level counselors will be moved to rule instead of statute. And the requirement for marriage and family therapist associates to have a portion of their supervisor experience under a supervisor with 5 years experience will be reduced to 2 years to align with all other master's level counselor professions. Effective January 1st, 2028, agency affiliated counselors will be eligible to practice in federally qualified health centers. As mentioned briefly, Washington has also joined the Interstate Compact for Social Workers. The effective date for this change depends on actions in other states' legislatures, so we do not know exactly when this will be effective. Currently, 6 states have adopted the compact, with approximately 20 other states having pending legislation. 7 states must adopt the compact before it can take effect. The department also made a number of recommendations for rule changes in our 2023 recommendations. Section 6 of INGRO's second substitute House Bill 7024 requires the department to adopt the following changes via emergency rule by July 1st, 2024. Emergency rules are short-term, so each project on this and the next slide will begin permanent rulemaking as soon as possible. All these projects will have public meetings for input from interested parties, and we share those invitations through our email service, GovDelivery. We encourage you to join the GovDelivery list for any professions for which you are interested in getting notifications of workshops or rules hearings. Join any of our GovDelivery lists, visit our website at doh.wa.gov, scroll to the bottom of the page, and click on Sign Up for Updates from DOH. First, we have several rulemaking recommendations for substance use disorder professionals and trainees. The department has drafted emergency rules as required by Engross Second Substitute House Bill 1724, and they are currently under review. We anticipate the emergency rules will be filed and effective in early summer. The department also filed the CR 101 to begin the permanent rulemaking process. Here, we have the rulemaking recommendations we made last year for master's level counselors in psychology. The master's level counselor program has held workshops and drafted emergency rules, which are currently under review. We anticipate these rules will be filed and effective by July 1st, 2024. The department will file a CR 101 to begin the permanent rulemaking process in the next few months. The Examining Board of Psychology has also begun rulemaking on these recommendations. The board is working on drafting emergency rules to implement the recommendations and anticipates finalizing these rules at their May 17th board meeting. We anticipate these rules will be filed by July 1st, 2024. Board staff are also simultaneously working on filing a CR 101 to begin the process of permanent rulemaking. They will be holding workshops in the coming months. So if you're interested in learning more or participating in those workshops, we encourage you to join the Psychology GovDelivery list. We would also like to note that we heard many serious concerns in our 2023 listening sessions about bias in the social work or ASWB exam. We did not have time to sufficiently study the issue and make a recommendation last year, but we have been working hard with a group of interested parties in the interim. We will have more information to share about this when we convene again towards the end of the summer to gather your feedback. Today, we are seeking your input to determine what rules or laws continue to present barriers or what barriers persist that we were not able to recommend solutions for last year. Your feedback is essential to us. It'll help direct our efforts and make recommendations to the legislature for additional statute and rule changes to reduce licensing barriers for behavioral health professions. Now, we have a few items we'd like everyone to keep in mind during this listening session. Please be mindful and respectful of all attendees and staff. Please raise your hand if you wish to provide verbal comment, and if applicable, state the name of the group or association you represent. Due to the number of participants today, please limit your comments to 2 minutes to allow everyone to speak. Also, please stay on topic of behavioral health licensing barriers. We will keep this slide up during the public comment period for all of you to reference the guiding questions we have provided. Your comments do not have to be specific to one of these questions, but please keep your comments to things the department has the authority to address. I'll provide an example. We know provider salaries pose a significant barrier for some professions, but the department does not have the authority to affect provider salaries. Also, we want to note that we are here today to hear from you. We will respond to technical questions or if anyone needs technical assistance on this Zoom, but we generally won't be responding to other questions during this Zoom. You may put questions that you have in the chat or Q&A box, and we will collect them and try to follow up after the meeting. Or you can email the program manager for your profession. We have listed the names and contacts for them on the second to last slide. And as a reminder, we are recording this meeting. If you wish to share your comments verbally, please raise your hand using the Zoom hand raise feature, and we will call on you in the order that the hands went up. If you do not wish to have your voice recorded, please type your comments into the chat and we'll collect them for review after this meeting. You may also send your comments to Corey Tarswell via email by Sunday, May 19th. With that, we'd like to invite your comments. Jeffrey.
Hello. Thank you for your guys' time and passion in giving us all an opportunity to have input on the licensing process. My current barrier that I've run into the most has been around taking the test coming into licensing. So I have an LMHCA. And wanting to become licensed, I have to go through Pearson VUE. And I don't find it fair that the state has contracted with an outside entity that costs hundreds of dollars for a test that I don't see as beneficial to my client outcomes or me meeting ethical boundaries that or guidelines that the state would desire. As I have not seen any data-driven background on this test having a positive impact on my work, and especially if I've already passed a CREP accredited higher education, I feel as though that test should not be something either that is required or that should be provided outside of the state's direct creation of the test in an affordable manner. I am open to any feedback that says that the test is beneficial for client outcomes or therapists providing a better service, but I have not seen that in the research.
Jeffrey, thank you for your comment and your concerns. Teresa.
Hi, yeah, I am currently almost done. I'm all the dissertation at this point for my PhD in clinical. The biggest barrier that I am currently trying to work my way through is that I am not going to an APA accredited work. So I am going to an online university called Walden, and unfortunately they are not APA accredited. And so there is a great deal of the university is trying to get us some additional face-to-face hours. But once again, there is a significant difficulty here. I mean, the fact that they are allowing hours that were from Washington State University that were done online during COVID, that is, and yet our hours are not considered that way. We're having to do an additional 750 hours of face-to-face. And unfortunately, that may or may not actually meet credentialing requirements. And this is all before I can even sit for an EPPP. So, you know, these are definitely some consistent barriers to potentially being able to become licensed in the future.
Thank you for your comment, Teresa, and for sharing.
And we have Marissa.
Yes, thank you. I work at an agency that employs a lot of agency affiliated counselors, or AAC. So this comment is specific to that credential. We not infrequently have staff who leave their position and or the agency to go to a role or agency that does not require or use the AAC. And then when they come back to our agency and need the AAC again, they have to pay more than they would as someone starting out because their credential is identified as expired. They have to pay a $185 renewal fee, that would be typical, plus a $95 late penalty, plus a $50 fee for, I think it's called reissuance of expired credential. So that's a total of $330 for staff who typically are not making a lot of money. And it's not fair and it doesn't make any sense because I understand that the goal is to encourage people not to let their credentials lapse. That makes sense if you're in a position that independently practices, like a doctor or a psychologist. But by definition, agency affiliated counselors should not renew or people should not maintain the AAC credential if they are not at an agency that employs AACs or they're not in a role that does that work. So this is a barrier. It's a lot of money and it doesn't make any sense. I think that it has just been overlooked, that it doesn't make sense for this particular role as compared with maybe some of the other credentials. Thank you.
Thank you for your comment, Marissa. Other comments? I'm unable to see the chat. Is anyone from DOH? Do we have any questions from the chat or any comments from the chat?
Nope, we're managing and no hands yet, Joe.
Thank you. Marissa.
Hi. So I had a couple more. I thought I'd give other people a chance to chime in before I went on with mine. This is not so much about the laws and regulations, but it is a problem. We are trying to hold our staff, accountable to maintaining or not to maintaining, for applying in this context for the AAC. And it used to be, well, first of all, when people apply online, it shows as pending right away. So we, as the employer, are able to, see who has applied. However, staff who are required to apply on paper because of various issues, it used to be that the DOH marked those as pending in your system upon receipt of the application, but it's been quite a while now that does not happen until it comes up for review, which can be quite a bit later. I have someone who sent it via certified mail in December, early December, and it's still not showing up in the DOH system. So if she hadn't sent it certified mail, we wouldn't have evidence that she applied. So it's really a challenge for us that we have to rely on staff self-report whether they have submitted their application or not if they're not able to submit online. I would request that the DOH return to a system where, they open the mail, and if you guys have cashed the check or money order, you should be able to enter it into the system so that we can see when it has been received. Thank you.
Thank you for sharing that, Marissa.
We have Lisa.
Lisa.
Yes, I am functioning as a co-occurring disorder mental health provider. I was wondering if the Department of Health was taking into consideration making a unified license for that. I carry 2 licenses in order to be able to function. One is the SUDP, and the other one is my social worker associate license that I'm working on and moving into the clinical, independent clinical instead, which I was supposed to apply for it a year ago. So I've been working under the wrong one, and was not notified of that until I discovered it recently. So now I have 2 social worker licenses I am working on. So as you can see, it becomes kind of problematic. And especially since the SUDP costs a lot more to get recertified, renewed, I should say, as opposed to the social worker one. And so I was hoping that, I don't know if anyone has ever broached this concerns or, complications. I was just hoping that I could put that out on the floor for perhaps review.
Thank you for sharing that, Lisa.
You have Allison.
Oops. Mute. I need to mute.
Allison?
Hi, I didn't raise my hand to speak.
Oh.
Sorry.
Thank you. Lisa, I believe you had your hand raised for another comment.
Sorry, that was an accident. I was trying to mute myself and I hit the wrong button. I
Thank
was
you.
trying to mute myself and hit the wrong button. Sorry. I'm working on my small 12 mini and I don't have my glasses on. My apologies.
Totally understandable. Thank you. Andrew.
welcome.
Hi there. Going off of Lisa's comment about a co-occurring credentialing, having a SUDP and also a social work license, a barrier would be to also have, like, for me was like, what constitutes a mental health hour? What constitutes credentialing hours for both? That was unclear for, while obtaining both of these licenses. So having clarity on what overlaps would be greatly helpful for people in the future, I think. Thank you.
Thank you for sharing and for that comment, Andrew. Jeffrey.
Hello. I wanted to make sure I gave room to other people to speak first. Again, I heard during the presentation, and I realized I was going to go off script if I said this then, that there were potential other directions available for getting licensure through the EBOP, the Examining Board of Psychology. And I guess if I was to add just one more piece for public comment, that it would be nice to know where I could find extra information on that, because I've been trying to follow this this policy assessment and committee for a while, and I did not see that piece come out. And so if that was made a little bit more clear, it would be nice to know what alternatives to testing were available coming into the summer.
Thank you, Jeffrey. At the end of the presentation today, you will see an email from our psychology program manager, Nancy Delgado, and please feel free to email your inquiry to her directly.
Thank you.
Marissa.
Hello again, thank you. Again, my agency employs a lot of AACs, agency affiliated counselors. And we have several wonderful staff who have lived experience with the criminal justice system. And they are required to submit a lot of documentation about their criminal history and court documents, including certified documents directly from the court, which is a significant burden in both time and money. I don't know exactly under what circumstances the DOH requires these, if it depends on the kind of criminal history or how long ago it was. So, I can't say personally whether I think it's reasonable or not, but I would encourage the DOH to look at what they're currently requiring and if there is a way that that burden can be reasonably reduced to allow staff who have lived experience to practice safely without undue financial burden. Thank you.
Thank you for sharing that, Marissa. Oh, we have a hand raised. Marissa? Marissa, you're on mute if you are speaking right now.
Hi, sorry about that. Okay, one more. This is again more of a logistics credentialing issue than a barrier per se, but it is a barrier sometimes to us being able to hold our staff accountable for getting the AAC credential. When we have staff whose credentials are pending for an extremely long time, it seems likely that it's not solely due to backlog on the DOH's part, but perhaps the staff dragging their feet. But to hold the staff accountable when we aren't kept informed. For example, we have someone whose credential has been pending in the DOH system since August of 2022. I thought that people had 90 days to submit required documentation. So I'm wondering if maybe something can be instituted to communicate with the agency when there are long delays about what needs to happen. Thank you.
Thank you for that comment, Marissa.
I think I'm done now.
It's all right if you have more. Any other comments? All right, I'm not hearing. We will, any further comment, we will give it a few more minutes. Thank you all thus far for your comments. And we do have time if there are more that come up. But while we wait for a few more minutes, if we don't have any more comments, we will wrap up with next steps. And then I would like to make this statement as well for everyone. If there were comments that you would have liked to make, but just didn't feel like today was the day to share them, please just send them to our program managers at the listed emails that you will see at the end of this session. Or you can also send them to me as well. And or Corey Tarswell, who you will see her email address as well at the end of this session. Okay, again, thank you all so much for your participation this afternoon. This information will be very helpful as we work to draft recommendations for improving the behavioral health licensing process. This is the final session of this series. Our team will spend the next few months reviewing comments, researching, and drafting preliminary recommendations. We plan to reach back out to you all in late summer to get your feedback on the preliminary recommendations before we present them to the legislature on or around November 1st, 2024. We have created a web page for this work and will be posting the recordings of these listening sessions in English and Spanish to our webpage, as well as video of the ASL interpretation. We will send out an email via GovDelivery with a link to the page shortly after the listening sessions have concluded. So before we go, I'd like to thank our wonderful interpreters for their hard work. Thank you. We appreciate your time and your help making our work more accessible to all Washingtonians. With that, we will close the meeting for today. Thank you all very much for your thoughtful comments and for the time you spent with us today. If you have any questions, please reach out to me or the appropriate program manager listed on this slide. Have a wonderful day, and thank you for serving all Washingtonians in your field in your profession. Have a great day, everybody.